Hello, and welcome to this presentation titled Partnering for Change Foundations for Clinical Leaders and Managers. This presentation provides foundational level knowledge about the model of partnering for change and is specifically designed for clinical leaders and managers who support the work of occupational therapists in school settings. The content of this presentation was developed by Sandra Sahagian-Whalen, Jennifer Kennedy, Leah Dix, and Winona Campbell. The presentation is narrated by Jennifer Kennedy on behalf of the P4C team. To start this presentation, we will share some important context that will provide an understanding of why Partnering for Change was developed. Historically, school-based services have taken a medical model approach. Children would come to kindergarten at age 4, and an educator would identify a child as having additional needs. But the child could not be referred into our health system until age 6 due to eligibility criteria. 2 years after starting kindergarten, the child would be referred to an occupational therapist. And if the child was accepted by the service provider agency, they were then put on a wait list for service. Across Ontario, wait times varied but were typically many years long. When the child made it to the top of the list, an OT would see them. But by then they might be reluctant to attend school due to long-lasting performance and participation challenges and facing mental health concerns, regardless of what the reason for the original referral was. The OT would take the child out of the classroom and work with the child, and then send them back to the classroom. The educator and family would not know what happened and wouldn't know how to help the child. Oftentimes, the child would be re-referred and then sit on the wait list again. This medical model approach did not work. Children waited for years for service that was ineffective because it came too late. Only the children with the highest needs would ever be seen, and educators wouldn't learn anything about managing these kids in the classroom. Beginning in late 2019, there was a change in the administration of school-based services from local community health agencies to the children treatment centers located throughout the province of Ontario. To address waitlists and to provide more equitable, needs-based occupational therapy services, many of the children's treatment centers began shifting to a new service delivery model called Partnering for Change. So how does Partnering for Change differ? When a child is struggling, the OT comes in and works with the educator right in the classroom, collaborating until they find a helpful solution for the child. Together, the occupational therapist and the educator change things in the classroom environment so that children who need the help can get it. Knowledge is shared and educators learn how to make the changes that children need, even on the days when the occupational therapist isn't there. We build capacity in the school system to support educators, families, and children. So what is Partnering for Change? Partnering for Change is an evidence-informed tiered model of occupational therapy services for all children in school settings. The model is often referred to by its acronym P4C, which reflects the partnership and the principles of the model. P4C promotes needs-based care for children during the school day. P4C supports all children who are in school and promotes inclusive education. Why should we implement P4C? Since 2008, P4C has been developed and evaluated through both qualitative and quantitative research involving key representatives from government, healthcare decision-makers, service provider organizations, clinicians, schools, and families working with the researchers. Our program of research has shown that P4C provides equitable access to occupational therapy services to support inclusion of all children, reduces waitlists and wait times, facilitates early identification of and early intervention with children needing occupational therapy support, supports children's ability to access the curriculum and participate successfully at school, builds capacity of educators, occupational therapists, and families to understand and support children's needs. Additionally, our hope is that schools that receive P4C and have these outcomes will also reduce the likelihood of secondary consequences like reluctance to attend school, academic decline, social isolation, and mental health concerns, which can occur due to repeated challenges in participating in daily tasks at school. Now we'll share the foundational components of the P4C model that help to promote these desired outcomes. Here is a visual of the P4C model, which will help to guide us through how it's enacted in schools. The first aspect of the model we want to highlight are the 4 C's in partnering for change. Building capacity in P4C is the process of strengthening the knowledge and skills, relationships, and resources of all involved. This approach emphasizes collaborative learning, shared leadership, and mutual support to empower educators, occupational therapists, and families to effect positive change. By enhancing the capacities of each partner, the model aims to create a more effective, sustainable impact, fostering a sense of self-efficacy and commitment amongst all partners. Building capacity is done through collaboration and coaching while in the context of the classroom or school. In P4C, collaboration is a dynamic, ongoing interaction that emphasizes shared goals and vision, mutual respect and trust, shared decision-making, co-creation of solutions, resource sharing, and shared responsibility for achieving positive outcomes. Coaching in P4C means modeling ways to support children in the classroom environment, sharing observations and explanations in the moment. For example, an OT might demonstrate how a specific strategy works in the classroom context and explain why the OT would choose that specific strategy for that situation. Then the OT can help support the educator to feel confident and competent implementing the strategy themselves. This is all happening in the context of the classroom or school. It is important to note that the context could mean the classroom, the gym, the area near the lockers, on the playground, or wherever the needs are occurring in the school. In addition to the 4 C's, there are 2 core activities that form the foundation for intervention offered within the P4C model. The first is relationship building. Building relationships with the school community, including children, families, educators, support service providers, and administrators, is essential to the success of P4C. To achieve this, the literature and our research suggest that the OT needs to be a regular and consistent presence in the school. This allows OTs to be available and seek opportunities to connect with the school community. A regular and consistent presence is necessary for the OT to establish relationships, foster an understanding of P4C in the school, and develop an understanding of the school and student needs. Because the OT has a regular and consistent presence, educators gain an appreciation that P4C is different than the services their school has received in the past, supporting the building of trust with the OT. Because the OT has time to build relationships in the school community, they feel validated and supported to effectively implement P4C. So what does a regular and consistent presence mean? When transitioning to the P4C model, our research suggests that 1 full day, no less than once every 2 weeks, is required to deliver all 3 tiers. We know that it takes time before you see all the outcomes of P4C, and an ongoing, regular, consistent presence is essential while you are still striving to see all the desired outcomes of P4C. Our recommendation is that you would maintain a frequency of once every 2 weeks until you have at least the following evidence. Students have equitable and timely access to OT services at all 3 tiers. Educators and OTs have increased capacity evidenced by greater understanding of and ability to meet children's needs. Student and school needs are being met as indicated by evidence of reduced waitlist and wait times, increased student participation at school, and educator and family satisfaction with the service. The occupational therapist reports a manageable workload, and there is evidence of school and student needs being met that would support a change in service frequency. The second core activity that is foundational for all services offered is knowledge sharing. Knowledge sharing means that the OT is able to provide evidence-based information on how to support children's participation in a way that educators can use in the classroom and families can use at home. The goal of knowledge sharing is to build the capacity of others by problem solving together, identifying and demonstrating strategies that enable successful participation, and then explaining how, why, and when particular strategies work. Educators and families can then apply these strategies when appropriate and adapt this knowledge to their day-to-day activities. Our research suggests that knowledge sharing is reciprocal and bidirectional. Not only do P4C OTs share knowledge with all involved, but they also enhance their own capacity and knowledge through collaboration with educators, children, and families. For example, as P4C therapists learn about the curriculum, school resources, and the demands on children and educators through knowledge sharing by the educators, they begin to understand what is feasible and realistic, and what can actually work in the context of the school or classroom. They also learn about how to align what they know with the demands of the curriculum. Next, we will bring your attention to the triangle in the middle of the model. This triangle is called the response to intervention pyramid and highlights the types of services included in the P4C model. As shown here, there are 3 types of services included: universal services, targeted services, and individualized services. All tiers are essential to the overall function of P4C and contribute to the outcomes of equitable access, inclusion, earlier identification, and earlier intervention. If a service provider decides that they are unable to complete one of the tiers, for example, they find themselves not having time to complete targeted services, then the model they are choosing to implement is not P4C. Additionally, the way in which the tiers are delivered is reflective of the needs of the school community. For example, some schools might have more time in Tier 1 or more time in Tier 3. This means there is no perfect prescription of time spent in each tier, and that it might look different at each school. As the OT gets to know the needs of the school, clinical reasoning will guide the services provided in each tier. Our research indicates that mentorship and peer support are essential in supporting OT's application of clinical reasoning in the P4C model. The arrows at the side of the response to intervention pyramid show that as the intensity of the P4C services increases, the number of students needing services at that level simultaneously decreases. By using a tiered approach, the P4C model enables many diverse student needs to be met by ensuring that the level of support is needs-based and reaches all students, from those who only need classroom-wide supports to those who need customized and individualized strategies to maximize their potential. We want to emphasize that the highlighted arrows do not indicate the path that all students take. They refer to the intensity of services and how the number of children at each tier decreases with increasing intensity of services. Students can enter the model at any tier dependent on their service needs. For example, a new student who requires use of a wheelchair and a change table for toileting will need the OT to provide individualized services to teach educators how to transfer the student safely and to assess the school environment in terms of accessibility for the student. However, this student might also benefit from Tier 1 services in the classroom. For instance, the OT might be supporting the educator to consider options of different forms of written output for all students in the classroom. At Tier 1 Universal Services, occupational therapists use their knowledge and skills to collaborate with educators to apply universal design for learning principles to educational materials, instruction, and school and classroom environments for the benefit of all children. OTs engage in capacity building by sharing knowledge with educators regarding when, why, and for which students a strategy or environmental modification would be chosen from the buffet of options available, and by demonstrating how to implement the needed changes. In other words, Tier 1 universal services are beneficial for all children, but may be essential for some to support school participation and access to the curriculum. Knowledge sharing and capacity building at Tier 1 are also provided to the whole school community, including families. For example, the OT may be asked to support the development of an inclusive, accessible playground or library space, or provide a family education evening on topics such as summertime activities to support motor skill development. Knowledge sharing may happen informally through hallway or staff room conversations, or more formally through lunch and learns or professional development day activities on topics such as are they ready to write or classroom design to support regulation. In terms of consent for Tier 1 services, when a tiered model of service is being implemented, at minimum, we suggest that a letter, email, or other communication be sent to all families in the school that includes the following information: that OTs are regulated health professionals, the role of the occupational therapist, the types of activities and services that the OT will be providing at Tier 1, that caregivers will be contacted by the OT or the educator if there are specific concerns regarding their child, and the contact information for the OT so the caregiver knows who to contact with questions or concerns. It is important that all families be informed that an OT will be present in the school because the OT might visit all of the spaces and classrooms in the school as needed throughout the school year. The communication also needs to clearly describe the types of Tier 1 universal services that are to be provided. The aim for the communication is to be as clear as possible about the service so that families are not surprised by the presence of the OT in the classroom and are familiar with some of the areas that the OT will focus on with all children to promote their success. We strongly encourage you to consult with the OT regulatory body in your jurisdiction of practice to ensure adherence to regulatory guidelines and best practices. Please note that anyone can consult the College of Occupational Therapists of Ontario. It does not need to be done by an OT. OT services at Tier 1 must be documented in a school or classroom file. It is important to note that the OT must not include any individual names or initials in this documentation. The nature of universal services is classroom or school-wide. Consult with the regulatory body in your jurisdiction of practice regarding the content and retention period required for these records. Now we'll talk about a few universal services examples. The first is how an OT might promote social and emotional well-being in the classroom at the Tier 1 level. This could include training for educators and staff on regulation programs and frameworks designed by OTs, such as the Zones of Regulation or the ALERT program. The OT can then help educators with the application of these programs into their classroom and other school settings. Supporting educators in designing classroom environments that support well-being, for example, the creation of calm classroom spaces. Providing training for educators and staff on ways to promote social and emotional well-being in the school environment. Delivering class-wide sessions on deep breathing, mindfulness, yoga, and/or regulation, and integrating a variety of tools and activities needed for social and emotional well-being that can be easily accessed by all students, such as noise-canceling headphones or weighted lap pads or quiet dim-lit spaces. These are all examples of universal services aimed to create a supportive environment for all students, not just those with identified needs, fostering social and emotional well-being, self-care, and enhancing overall classroom engagement and productivity. Promoting written productivity in the classroom is another universal services example. Strategies an OT might implement include providing strategies to educators on how to support development of pencil grasp, completing a class lesson on working hand versus helping hand, line use, and spatial organization of the page, professional development for educators regarding options and considerations for different forms of written output, distributing resources and activity ideas for families to reinforce written productivity practice at home, fostering a collaborative approach to skill development. These are all examples of universal services aimed to enhance written productivity for all students, supporting their overall academic performance and promoting confidence in their abilities. The second tier of the response to intervention triangle, shown in the center of the triangle, is targeted services. At Tier 2, some children may require additional support to participate and access the curriculum, despite the provision of OT interventions for all children through Tier 1 services. Tier 2 targeted services are required to meet the needs of these children who require short-term, targeted interventions focused on their specific needs. These interventions happen in the context of the school to support generalization to the school curriculum. The OT monitors the child's response to Tier 2 interventions provided either individually or in a group setting to determine if more intensive or longer duration and/or highly individualized interventions at Tier 3 are necessary. Successful strategies to support students at Tier 2 are shared with the educators and their families. When a tiered model of service is being implemented, at Tier 2, the OT is focused on specific children who are receiving targeted short-term interventions. Tier 2 services, therefore, require informed consent of the child, if applicable and appropriate, and family or substitute decision maker. A clinical record is required for each child receiving Tier 2 services. Consult with the regulatory body in your jurisdiction of practice regarding the content required to meet their standards for record keeping. Consult with the regulatory body in your jurisdiction of practice regarding the content required to meet the standards for record keeping. In P4C, OTs use dynamic performance analysis rather than static assessment. The therapist conducts dynamic assessment in context wherever the issue is occurring and brings in their expertise, knowledge, and skills to analyze the task, the environment, and the child's performance. Unlike static assessment, dynamic performance analysis allows the therapist to determine the child's current level of function performing a task in the natural environment. The therapist trials a variety of supports and strategies to evaluate which is most helpful to the child. An important component in P4C is that the therapist communicates with the educator and family about what was done and why to build the capacity through knowledge sharing. In targeted services, the OT, in collaboration with the educator, monitors the response to interventions over time. They determine whether the child's participation or performance has been enhanced by the trial strategies or if something else needs to be tried. This is called response to intervention. If the trial strategy is working well to support the child, then a specific plan will be created with collaboration between the OT, educator, and family. Through monitoring the response to the Tier 2 targeted interventions, it can be determined whether more intensive, longer duration, and/or highly individualized interventions at Tier 3 are necessary. The third tier at the top of the response to intervention triangle is individualized services. Fewer children will require additional support beyond Tier 1 and 2 supports to participate and access the curriculum. Tier 3 individualized services focus on the fewer specific children who have more complex needs. The OT and educator may collaboratively identify these children based on their responses to the strategies implemented at Tiers 1 and 2. Alternatively, some children might access OT services beginning at Tier 3 because of previously identified needs or the complexity of their needs. For example, a child who received OT prior to school entry and who requires individualized services to support their transition to school might enter the P4C model at Tier 3. Children receiving Tier 3 services may require additional support to improve skills, accommodations to facilitate successful participation and access to the curriculum, specific environmental modifications, and/or have specific equipment needs. There is no change in the consent and documentation processes for Tiers 2 and 3. We encourage OTs to use their clinical judgment to determine what needs to be discussed or included in communications with children, families, or substitute decision makers, and when obtaining informed consent for Tier 2 and Tier 3 interventions, to ensure this meets the standards and regulations in the OT's jurisdiction, and of course follows typical standards for documentation and record keeping. The last part of the model we want to highlight is the outer circle, which emphasizes the collaboration and equal partnership that is required amongst educators, children, families, and OTs to support the inclusion, participation, and well-being of all children through a tiered model of service. In particular, we want to highlight considerations when partnering with families. P4C research has shown that partnership with families can be challenging. Factors that have been shown to influence the family-therapist relationship include competing demands on OTs and families' time, families' awareness of the service, families and OTs' readiness to engage, the relationship that the OTs have with the schools and educators, unique socio-demographic factors in school communities, and the consistency and availability of OT services. Many of these factors can be a challenge to the family-therapist relationship. However, our research shows that if OTs have a strong relationship with the educators and school staff, this can help to build connections with families as well. Additionally, the consistent presence and availability of the OT throughout the school year can positively influence the family-therapist relationship by allowing families to have more comfort with the therapist and more opportunities to connect throughout the year. At Tier 1, the OT might engage families by sharing information through classroom or school newsletters, providing a family information evening on a topic of interest to all families, such as the promotion of independence and self-care, making videos and written resources that are good for all, attending a school open house. Sharing information with families using these strategies may enhance their awareness of the knowledge, skills, and role of the OT in supporting all children. Ensuring families can contact them with questions about OT or the service creates opportunities for families to initiate contact with the OT, which may support family engagement. As we've discussed, prior to receiving Tier 2 and 3 services, the OT needs to speak with families to gain informed consent. This initial conversation allows the OT to begin to develop relationships with individual families. During this interaction, the OT communicates and clarifies their role and scope of practice, and families share their child's strengths and needs, and ongoing communication methods and expectations are discussed. The therapist continues to connect with families throughout the services to foster collaboration, knowledge sharing, and the co-creation of specific plans for the child. OTs must also discuss any changes to service with families to maintain ongoing informed consent. There are many strategies that can be implemented to foster the family-therapist relationship and family engagement at Tier 2 and 3. For instance, virtual workshops and video conferencing can be used to share information and demonstrate to families the strategies, tools, and resources that might support their child's participation. OTs can also be available during family educator interview evenings and open houses for meetings with specific families. Additionally, hosting occupational therapy office hours, where the OT is available by telephone, video conferencing, or in person, might also support family engagement. In summary, the P4C tiered model considers the needs of the child, educator, school, and family when determining the services that are required. The model reflects the partnership between therapists, families, and educators to create physical, social, and learning environments that facilitate successful engagement and participation for all children. Working from a foundation that focuses on relationship building and sharing of knowledge, these partners collaboratively implement tiered services to meet the needs of all children in the school. This concludes the P4C Foundation's content for clinical leaders and managers. Thank you for taking the time to learn about P4C and its implementation in school settings. If you would like to learn more about P4C, our team has developed some resources that can be accessed at no cost. The Partnering for Change Professional Development Program is freely available on machealth.ca. It provides users with an in-depth learning experience about P4C and its use in schools. Additionally, the first course, first kit, and FAQs provide occupational therapists, speech-language pathologists, and physiotherapists with evidence-based information and tools to support the implementation of a tiered model of service in schools. These are also freely available on machealth.ca. Using a tiered model of service delivery is a major change for providers, so we have compiled a list of frequently asked questions and hope we have answered yours in this FAQ resource. Lastly, the first kit provides resources, tools, and practical strategies to support the learning needs of therapists in the provision of inclusive rehabilitation services in schools and early child care settings using a tiered approach. You might find some of the resources helpful in understanding, supporting, and facilitating P4C in your setting.